Welcome to the deep dive. Today we're taking a close look at something we probably don't think about much until, well, until there's a problem.
Hmm.
Our salivary glands.
Yeah.
These are the workhorses of our mouths, constantly producing saliva. But things can go awry, ducts can get blocked, saliva can't drain properly. We'll explore everything from those minor irritating blockages to more significant issues.
Right.
Interestingly, what our sources show is that the majority of salivary gland tumors are actually benign, and those smaller blockages, often they can just result on their own.
That's right. And to really get a handle on this surprisingly varied area, we've looked at our sources and organized the different salivary gland conditions into like 4 main groups.
Okay.
We'll start with reactive lesions. These are the more common issues, the ones that arise from local irritations or injuries. Then we'll move on to infectious conditions, followed by benign growths, and finally, malignant growths. Think of this structure as a way to make sense of the different things that can affect these glands.
Okay, let's dive into that first category, reactive lesions. It sounds like these are the everyday bumps and bruises, sort of our salivary glands.
Precisely. And a frequent one is mucus extravasation. This usually happens when a salivary gland duct experiences what you might think of as a traumatic cut or rupture.
Right.
When that occurs, the mucus inside, well, it leaks out into the surrounding tissue.
Ouch, that sounds uncomfortable. What would someone notice if this happened?
Typically, it shows up as a painless, smooth little bump right on the surface. What's interesting is that it often has a bluish color. You'll most often find it on the lower lip.
A bluish bump on the lip. That's a pretty specific picture. What's happening beneath the surface to cause that?
Well, when the mucus escapes, it's called mucin extravasation. The body reacts to this foreign material, triggering inflammation. You'll see immune cells trying to deal with the escaped mucus, new blood vessel formation, that's the granulation tissue, and signs of the body trying to repair the damage, which leads to some scarring.
Now, if you saw a bluish lump in your mouth, your mind might race to some, serious possibilities. What else could it potentially be?
That's a very valid thought. The differential diagnosis could include things like actual salivary gland tumors or even vascular malformations. However, the typical appearance of a mucus extravasation, that painless, smooth, bluish bump on the lower lip, is usually quite distinctive visually.
So how do you fix a cut duct and escaped mucus? What's the treatment?
The usual approach is surgical excision of the lesion itself. But importantly, you also need to remove the associated minor salivary gland.
Oh, okay.
If that damaged gland is left in place, it will likely continue to produce saliva that will just, leak out again.
That makes perfect sense. Remove the source of the problem. All right, let's move to our next reactive lesion. Mucus retention cysts, also known as obstructive ceolidinitis. That sounds like something a bit different.
It is. In this case, instead of a physical cut, we have a blockage of the normal flow of saliva. This obstruction causes mucus to back up and be retained within the salivary duct system itself, forming a cyst.
And what typically causes that blockage? What's the main culprit?
The most common cause is a silolith, which, as we mentioned earlier, is basically a salivary stone.
Right, a stone.
These little mineral deposits can form within the ducts and obstruct the flow of saliva. Less frequently, the blockage could be due to scarring around a duct or even pressure from an external mass like a tumor.
Salivary stones.
Yeah.
What exactly are they made of? They sound a bit like kidney stones, but in your mouth.
There are some similarities, yeah. They're mineral deposits, primarily calcium salts, things like calcium carbonate and calcium phosphate, that gradually precipitate around a tiny central core. This nucleus could be a bit of thickened mucus, cellular debris, or even bacteria.
Where in the mouth do these blockages most often occur? Which glands are most susceptible?
The submandibular glands, those located under your jaw, are by far the most frequent site. Our sources indicate they account for around 80% of iolithiasis cases.
Wow, 80%.
Yeah. The parotid glands near your ears are next, making up about 20%. You can see them in the sublingual glands and the smaller minor salivary glands as well, but it's much less common there.
So what would someone experience if they had a salivary stone blocking a duct?
The classic symptoms are intermittent pain and swelling in the affected area, and these episodes are often noticeably worse around mealtimes.
Huh? Makes sense.
Think about it. When you eat, your salivary glands ramp up saliva production. If there's a stone blocking the duct, the pressure builds up behind it, causing pain and swelling. Sometimes, if you gently massage the affected gland, you might even see a cloudy, yellowish, or even pus-like discharge coming from the duct opening.
Oh, that doesn't sound pleasant at all. The sources also mentioned a plunging ranula as a potential complication. We'll get to ranulas in a moment, but what makes one plunging?
Okay, so a plunging ranula is a specific scenario that can arise if a mucus retention issue, usually in the sublingual gland under the tongue.
Right.
It dissects through the mylohyoid muscle. This muscle forms part of the floor of the mouth, and if the mucus pushes through it, it can extend into the neck, creating a swelling there.
Okay.
That's the plunging aspect. It goes below the floor of the mouth.
And what about when these blockages happen in those smaller, minor salivary glands? How do they typically present?
Quite often, blockages in the minor glands present as swellings that don't cause any pain. They might feel like small, mobile lumps under the surface and might not have any history of obvious injury.
Now, how do doctors determine if it's a stone versus something else causing a salivary issue? I imagine imaging plays a role here.
Absolutely. Radiographs, like standard x-rays, are often the first step. What's interesting is that submandibular stones are usually radiopaque, meaning they contain enough minerals like calcium to show up quite clearly on an x-ray.
Okay.
Parotid stones, on the other hand, are often radiolucent, meaning they don't block x-rays as much and can be harder to see on a regular film because, well, parotid saliva has a different mineral composition.
Oh, interesting difference.
Yeah. If a standard X-ray isn't conclusive, other diagnostic tools like retrograde coelography, where a contrast dye is injected into the salivary duct, or even CT scans can provide more detailed images.
And if you were to look at a mucus retention cyst under a microscope, what would you see?
Histologically, you'd see a cyst-like space or cavity lined by a layer of ductal epithelial cells. This lining can vary a bit. It might be pseudostratified columnar in some areas, or even transform into stratified squamous epithelium, a more protective type of lining, possibly in response to chronic irritation. Sometimes you might even see oncocytic changes, where the cells become enlarged and filled with mitochondria, again, often due to inflammation or cellular stress. The cyst itself would be filled with that retained mucus, and you might even see the obstructing cylith right there within the cavity. The surrounding tissue usually shows relatively little inflammation.
So how do you treat a mucus retention cyst? It sounds like the approach might depend on where it's located.
Precisely. For issues in the minor salivary glands, the usual treatment is to surgically remove both the cyst and the associated gland to prevent recurrence.
Right.
For the major salivary glands, particularly the submandibular gland, the approach depends on the location of the stone. If the stone is deep within the gland's ductal system, close to where the ducts branch, the hilum,
Okay.
it can be very difficult to remove, and in some cases, removing the entire gland might be considered. However, if the stone is located closer to the opening of the duct, sometimes it can be surgically removed directly through an incision in the mouth or even gently milked out through the duct orifice.
Milked out, really?
Yeah, sometimes. Other procedures, like marsupialization, where the cyst is opened up and its edges are stitched to the surrounding tissue to create a pouch that stays open and allows drainage.
Ah,
Or placing a small tube called a cannula into the duct to help with drainage and healing might also be used. It's important to note that these cysts can sometimes come back, with recurrence rates reported up to around 20%.
that is a significant chance of recurrence. Okay, moving on. Let's talk about ranulas. We touched on the plunging version, but what is a typical ranula?
A ranula is essentially a specific type of mucocele, that mucus-filled swelling we discussed earlier, that occurs in the floor of the mouth.
Okay.
It's specifically linked to the sublingual salivary glands, which are located under the tongue, and sometimes the submandibular glands can also be involved.
And what causes these mucociliary specifically in the floor of the mouth?
Similar to the mucus extravasation we talked about initially, a ranula typically results from a rupture or blockage of a salivary gland duct, leading to the accumulation of mucus in the surrounding soft tissues.
Huh.
When this happens with the sublingual or submandibular glands in the floor of the mouth, it manifests as a ranula.
What does a ranula look like? I can picture the plunging one in the neck, but what about in the mouth itself?
In the mouth, it appears as a fluctuant, meaning it feels like it's filled with fluid, soft tissue mass, usually on just one side in the floor of the mouth.
Right.
Because the lining of the mouth in that area is quite thin, the trapped mucus often gives the ranula a characteristic bluish, somewhat translucent appearance. The sources often describe it quite vividly as resembling a frog's belly.
A frog's belly, huh?
Yeah, if it grows large enough, it can even push the tongue to the side or upwards, which can be quite uncomfortable.
That does sound uncomfortable. And if you looked at a ranula under a microscope, would you see something similar to the mucus extravasation?
There are indeed similarities. You'd see that extravasated mucin within the connective tissue, triggering an inflammatory response as the body tries to wall it off.
Okay.
You'd see immune cells like neutrophils and macrophages, as well as granulation tissue forming. The associated salivary gland, particularly the sublingual gland, might show signs of dilated ducts, chronic inflammation, some degeneration of the acinis, those little mucus-producing units, and the development of interstitial fibrosis, which is basically scarring within the gland tissue.
So, again, the body's trying to react to and contain the leaked mucus. What's the best way to treat a ranula in the mouth?
The most effective treatment is surgical excision of the ranula itself, and importantly, the associated minor salivary glands, especially the sublingual glands, which are often the source of the problem.
I get the source.
Exactly. Simply draining the ranula with a needle, aspiration, usually doesn't provide a long-term solution because the underlying gland continues to produce saliva that will just refill the cyst.
That makes sense.
Hmm.
Okay, next on our reactive list, maxillary sinus mucosalis. Now, we're moving a bit outside the main oral cavity here, aren't we?
Yes, we are venturing into the maxillary sinus, which is an air-filled space in the upper jaw. Maxillary sinus mucosalis, sometimes also referred to as retention cysts or pseudocysts in this location, are actually very common findings when people have panoramic dental x-rays taken.
Ah.
Often, they are entirely incidental discoveries and don't cause any symptoms whatsoever.
So if they're usually harmless, why are they something we need to be aware of?
Well, it's important to understand what they are and to know that in the vast majority of cases, they don't require any treatment. There's a subtle difference in how these arise in the sinus. A true retention cyst is thought to develop from a blocked seromucous gland within the lining of the sinus.
Okay.
This blockage leads to the formation of a cyst that is lined by ductal epithelium and filled with mucus. A pseudocyst, on the other hand, is believed to be inflammatory in origin.
Inflammatory.
Yeah, it likely results from fluid accumulation within the sinus membrane, perhaps due to a previous infection or an allergic reaction. The key difference is that a pseudocyst lacks that true epithelial lining.
Lined versus unlined, that's the key histological distinction. But clinically, how do these present, if they present at all?
Most of the time, as we said, they are completely asymptomatic. Occasionally, a patient might report a vague feeling of pressure or slight tenderness in the cheek area on the affected side. Very rarely, if they grow quite large, there might be a palpable expansion.
And on an x-ray.
On an x-ray, both retention cysts and pseudocysts typically appear as a smooth, dome-shaped, uniformly opaque lesion that is well-defined and attached to the floor of the maxillary sinus.
And what other things might a radiologist see in the sinus that could be mistaken for a mucosal? What's the differential diagnosis here?
You want to consider things like inflammatory nasal polyps that have extended into the sinus, thickening of the sinus lining that could be due to a dental infection spreading upwards, actual maxillary sinusitis, and even, though less common, neoplasms that could arise within the sinus itself.
But given that these are usually benign and asymptomatic, the treatment approach is pretty conservative, I would imagine.
Absolutely. Because they tend to grow very slowly, if at all. The usual approach is simply no treatment, just periodic observation with follow-up x-rays to monitor if there are any changes.
All right, the final stop on our reactive lesion journey is necrotizing xylem metaplasia. This one definitely has a dramatic-sounding name.
It does, and clinically it can be quite striking. The sources emphasize that this is a reactive condition that typically occurs on the palate, the roof of the mouth, and can actually mimic malignancy.
Wow.
Both in its appearance and even under the microscope. This is precisely why it's so important for clinicians to recognize it, to avoid unnecessary and potentially radical surgical procedures.
Mimicking malignancy, that's certainly something you want to be able to distinguish.
Yeah.
What is believed to cause this somewhat alarming condition?
The strongest theory is that it's caused by ischemia, which is a reduction in blood flow to the salivary glands located in the palate.
Okay, lack of blood flow.
Exactly. This reduced blood supply is often thought to be triggered by some form of local trauma. This could include surgical procedures performed in the area, dental injections given in the palate, or even just the administration of local anesthesia. The lack of sufficient blood flow then leads to infarction or tissue death of the affected salivary glands, followed by a change in the ductal cells called squamous metaplasia, where they transform into a more squamous-like cell type.
Squamous metaplasia, we've encountered that term before in other contexts.
Yep.
What's a typical way this condition progresses? What would someone experience?
It often begins as a tender swelling in the palate with a dusky redness of the overlying mucous membrane. This area then breaks down, forming a sharply demarcated, deep ulcer.
Ouch.
Well, what's quite interesting and a key diagnostic clue is that despite how alarming this ulcer can look, it's typically painless, or the level of pain is surprisingly minimal compared to the size and appearance of the lesion.
Really? Painless?
Yeah, often. The base of the ulcer often has a characteristic yellowish-gray, somewhat lobular appearance. These lesions can vary in size and can occur on one or both sides of the palate, and the healing process for necrotizing silometaplasia is typically quite protracted, often taking anywhere from 6 to 10 weeks to fully resolve.
6 to 10 weeks for a relatively painless ulcer that looks concerning. That's a long time to wait and worry. What did pathologists look for under the microscope to confirm it's necrotizing silometaplasia and not something cancerous?
The key microscopic features are the presence of necrosis, or cell death, in the salivary glands, along with that squamous metaplasia of the duct epithelium. Importantly, the overall lobular architecture of the salivary gland tissue is preserved. You can still see the outlines of the original gland structure,
Ah, okay.
which helps to differentiate it from a true neoplasm where that orderly architecture is typically disrupted. Also, unlike in cancerous conditions, the cells don't show cytological atypia. They don't look abnormal or malignant at a cellular level.
And what are the critical differential diagnoses that a pathologist would need to rule out in such a case?
Well, given its clinical and even microscopic similarities, squamous cell carcinoma and other malignant minor salivary gland neoplasms are very high on the list of things to exclude.
Right.
You would also need to consider other conditions like syphilitic gummas, which are lesions associated with late-stage syphilis, and deep fungal infections, particularly in individuals with weakened immune systems.
So, once a diagnosis of necrotizing silometaplasia is confirmed, what's the good news for the patient?
The very good news is that it is a completely benign and self-limiting condition.
Phew.
It doesn't require any surgical intervention beyond perhaps a diagnostic biopsy if the clinical picture isn't entirely clear. The body will naturally heal itself over those several weeks. The main aspects of management involve reassuring the patient about the benign nature of the lesion, perhaps recommending gentle saline mouth rinses to keep the area clean, and offering pain relief medication if they experience any discomfort in the initial stages.
What a relief that something so alarming looking can resolve on its own. Okay, we've thoroughly explored the reactive lesions. Now let's shift gears and move into the category of infectious conditions that can affect the salivary glands. First up, a classic that many of us remember, at least from stories.
Mumps.
Yes, mumps is an acute viral infection that primarily targets the parotid glands, which are the largest salivary glands located near your ears. It used to be a very common childhood illness before the widespread implementation of the MMR vaccine. The measles, mumps, and rubella vaccine, right?
Yeah.
And the cause is a paramyxovirus, correct.
Yeah.
And it spreads through contact with saliva.
Exactly. It's transmitted through direct contact with respiratory droplets that contain the infected saliva of someone who has mumps. The incubation period, the time between exposure and the start of symptoms, is typically around 2 to 3 weeks.
What are the telltale signs and symptoms of mumps?
Initially, patients often develop general viral symptoms such as fever, malaise, that general feeling of being unwell, headache, and chills. The hallmark sign, of course, is the swelling of one or both parotid glands.
The chipmunk cheeks.
Exactly, the chipmunk cheeks. It often starts with swelling on one side and then becomes bilateral, affecting both parotid glands in about 70% of cases. The swelling usually reaches its maximum size within a couple of days and can make the cheeks appear quite puffy. There's often significant local pain associated with the swelling, especially when moving the jaw, like when talking or chewing.
Yeah.
The sources also mention that Stenson's duct, which is the main duct from the parotid gland, can become partially blocked due to the swelling. This can cause a sharp increase in pain, particularly when eating or drinking things that stimulate saliva production, like pickles or lemonade.
That makes sense. A blocked duct, when the gland is trying to produce more saliva, would definitely lead to pressure and pain. How long does the parotid swelling typically last in the case of mumps?
The swelling usually begins to subside within about 10 days after the onset of symptoms. It's important to remember, though, that mumps is a systemic infection. The virus can spread and affect other parts of the body beyond just the salivary glands.
Like what?
This can include other glands and tissues, such as the testes in males, the ovaries in females, as well as the pancreas, brain, and spinal cord.
And we often hear about potential complications associated with mumps. What are some of the more serious ones that can occur?
While most cases of mumps resolve without any long-term issues, there are some rare but serious complications. These can include viral encephalitis, which is inflammation of the brain, myocarditis, inflammation of the heart muscle, nephritis, inflammation of the kidneys, nerve deafness, and, as we mentioned, in males, orchitis, inflammation of the testicles. That can sometimes lead to testicular atrophy and, very rarely, infertility. This is a key reason why widespread vaccination has been so crucial.
Absolutely. The MMR vaccine has made a tremendous difference. The sources also briefly mentioned that there can be other, less common viral causes of peritonitis, which is just inflammation of the parotid gland.
Yes, while mumps is the most well-known viral cause, other viruses can also infect the parotid glands. These include viruses like Coxsackie virus, echovirus, cytomegalovirus, CMV, and various parainfluenza viruses, but these typically don't cause the classic widespread epidemics that mumps used to.
Okay, let's move to our next infectious condition, Sjogren's syndrome. Now, this feels quite different from an acute viral infection like mumps.
You're absolutely right. Sjogren's syndrome is an autoimmune disorder, not a direct infection caused by, a bug from outside the body. In Sjogren's, the body's own immune system mistakenly attacks the moisture-producing glands.
The tear glands and salivary glands mainly.
Primarily, yes, the lacrimal glands, which produce tears, and the salivary glands. This autoimmune attack, mediated by lymphocytes, leads to the destruction of these glands over time, resulting in the hallmark symptoms of dry eyes, or keratoconjunctivitis sicca, and dry mouth, or xerostomia.
So it's the body's defense system turning against itself. What might trigger this kind of autoimmune response? Is it known?
The exact cause of Sjogren's syndrome remains unknown, but it's believed to be a complex interplay of several factors. There's likely a genetic predisposition,
Okay.
suggesting some people are more susceptible. Environmental factors like viral infections are also suspected of playing a role in triggering the autoimmune response in susceptible individuals. And of course, there are underlying immunological abnormalities. Some research has suggested a possible link with Epstein-Barr virus, EBV, as a potential trigger.
Beyond the hallmark symptoms of dry eyes and dry mouth, what other symptoms might someone with Sjogren's syndrome experience?
Because it's a systemic autoimmune disease, it can affect more than just the tear and salivary glands. Patients might have significant difficulty eating and speaking due to the lack of saliva.
Right, that makes sense.
The reduced salivary flow also leads to a dramatically increased risk of dental problems like cavities, gum disease, and oral candidiasis fungal infections in the mouth. The parotid glands can also become enlarged, sometimes intermittently. Systemically, many patients experience significant fatigue and joint pain.
Wow, fatigue and joint pain too.
Yeah. Sjogren's syndrome can also affect other organs like the lungs, kidneys, blood vessels, and nerves, and it's often associated with other autoimmune diseases such as rheumatoid arthritis and lupus.
Given that it affects so many different areas and has a range of symptoms, how is Sjogren's syndrome actually diagnosed?
Diagnosis typically involves a combination of clinical findings, lab tests, and sometimes biopsies. Blood tests look for specific autoantibodies, particularly anti-SSA or Rho and anti-SSB or La antibodies. Tests to assess tear production, like the Schirmer's test and ocular staining score, provide objective evidence of dry eyes. And finally, a minor salivary gland biopsy, usually taken from the inner lip.
The lip.
Yeah, the labial salivary gland biopsy. It can show characteristic features like focal lymphocytic celedonitis, where you see clusters of lymphocytes infiltrating the gland tissue. Specific diagnostic criteria have been developed to help make a definitive diagnosis.
And how is Sjogren's syndrome managed? It sounds like it's more about alleviating symptoms and preventing complications than, say, curing an infection.
Precisely. Management is primarily focused on relieving the dryness symptoms and preventing long-term complications. Artificial tears and lubricating eye drops for dry eyes, and artificial saliva sprays, gels, and lozenges help with dry mouth.
Makes sense.
Maintaining excellent oral hygiene is absolutely crucial. Frequent brushing, flossing, fluoride treatments. Medications called sialagogues like pilocarpine and cevimeline can sometimes be prescribed to help stimulate saliva production.
Stimulate saliva.
Yeah. For more severe systemic symptoms, immunosuppressive drugs might be necessary. Because it's chronic, regular follow-up is essential. And it's important to note, individuals with Sjogren's have a slightly increased risk of developing lymphoma.
That's a serious consideration for those living with Sjogren's. Okay, let's move on to another systemic condition that can affect the salivary glands.
Yeah.
Sarcoidosis.
Yes, sarcoidosis is a multisystem inflammatory disease characterized by the formation of non-caseating granulomas in various organs.
Non-caseating granulomas. What does that mean exactly?
Non-caseating means that when these granulomas, which are like little clusters of inflammatory cells, are examined under a microscope, they don't show central necrosis or cell death, which is seen in some other types of granulomatous diseases like tuberculosis.
Got it. And the cause.
Like many autoimmune-related conditions, the cause of sarcoidosis is currently unknown.
And as with Sjogren's, are there any suspected triggers for this granulomatous inflammation?
Several potential triggers have been investigated, including certain infectious agents like atypical mycobacteria and propionibacteria, as well as viruses like EBV and HHV8. There's also evidence suggesting a genetic predisposition.
Sarcoidosis is known to affect many different parts of the body. What are some of the key clinical features that might be seen?
The clinical features are indeed quite diverse. General symptoms can include unexplained lethargy, chronic fatigue, loss of appetite. Pulmonary involvement is very common, often presenting with bilateral hilar lymphadenopathy, enlarged lymph nodes in the chest seen on X-ray, and sometimes leading to pulmonary fibrosis or lung scarring.
Okay.
Skin manifestations can include erythema nodosum, tender red nodules, usually on the shins, and lupus pernio, purplish plaques on the nose, cheeks, ears. Ocular involvement can cause uveitis.
And the salivary glands?
Yes, sarcoidosis can affect the salivary glands, particularly the parotids, causing enlargement. Sometimes this leads to Herfurth syndrome, that's a triad of parotid enlargement, anterior uveitis, and facial nerve palsy. Other organs, like the liver and bones, can be affected too. Oral manifestations can include nodular swellings and, as mentioned, parotid enlargement, which can cause xerostomia.
So a really wide array of potential symptoms. How is sarcoidosis typically diagnosed?
Diagnosis often requires a combination of clinical presentation, radiological findings, and lab tests. A biopsy showing those characteristic non-caseating granulomas is crucial. A chest X-ray often reveals the hilar lymphadenopathy. Blood tests might show things like hypercalcemia or elevated levels of enzymes like lysozyme and ADA.
And if you look at a biopsy under a microscope, what would those non-caseating granulomas look like?
You'd see well-defined clusters of epithelioid macrophages, specialized immune cells, along with multinucleated giant cells. Sometimes within these giant cells, you might find structures called asteroid bodies and shaman bodies, though they aren't always present or specific to sarcoidosis.
And the treatment approach for sarcoidosis?
In many cases, especially with mild symptoms or just lung involvement, it can actually resolve spontaneously.
Oh, really?
Yeah. But for more symptomatic cases or when vital organs are involved, corticosteroids are often the first-line treatment. Other medications like hydroxychloroquine, methotrexate, or other immunosuppressants might be used in more severe cases.
Okay, next in our list of systemic conditions that can impact salivary glands is scleroderma, also known as systemic sclerosis.
Yes, scleroderma is another chronic autoimmune disorder. It's characterized by the abnormal growth of connective tissue, leading to fibrosis and hardening of the skin and connective tissues. It can also affect internal organs like the heart, lungs, kidneys, and GI tract.
Cause unknown again.
Pretty much. Thought to involve immunity, genetics, and maybe environmental triggers.
Scleroderma is known for having some fairly distinctive clinical features, often remembered by the acronym CREST. Can you tell us a bit about that?
Yes, CREST is a useful mnemonic, particularly for limited cutaneous scleroderma, it stands for. C, calcinosis, calcium deposits in the skin. R, Raynaud's phenomenon, reduced blood flow to finger stones in cold stress.
Turning white or blue.
Exactly. E, esophageal dysmotility, problem swallowing. S, sclerodactyly, thickening tightening of skin on finger stones. And T, telangiectasia, tiny widened blood vessels visible on the skin.
And beyond CREST.
Scleroderma can also lead to a mask-like facial appearance from skin tightening, limited mouth opening, microscomia, dry mouth, xerostomia, from salivary gland involvement, increased risk of cervical cavities, resorption of the angle of the mandible, and widening of the periodontal membranes around teeth. Raynaud's is often one of the earliest signs.
It sounds like scleroderma can have a pretty significant impact on oral health. How is it typically diagnosed?
Diagnosis is based on clinical evaluation, those characteristic skin changes, internal organ assessment, and lab tests. Certain autoantibodies like anti-Sila70, anti-centromere, and anti-RNA polymerase III can be detected and help classify the type. ESR, a general inflammation marker, might be elevated too.
And if you were to look at salivary gland tissue under a microscope in someone with scleroderma, what might you see?
A skin biopsy would show increased collagen deposition, In the minor salivary glands, a biopsy might reveal interstitial fibrosis, increased fibrous tissue between the glandular units, and atrophy or shrinkage of the acini, the saliva-producing units.
And how is scleroderma generally managed?
It's primarily supportive, aiming to relieve symptoms and prevent complications, as there's no cure currently. Corticosteroids might help with inflammation early on, but long-term benefit is limited. Immunosuppressants can try to slow progression. Raynaud's is managed with vasodilators. Treatment for internal organs is specific to the organ affected.
Finally, in our category of infectious and systemic conditions, we have xerostomia, or dry mouth. Now, the sources we looked at made a really important point that while it's a common complaint, it's not simply a result of getting older.
That's a crucial point to emphasize. Xerostomia is a condition characterized by a subjective feeling of dry mouth due to a significant reduction in saliva flow. It's not a disease itself, but a symptom with a very wide range of underlying causes.
Right.
It's a common misconception that dry mouth is just a natural part of aging, and our sources clearly indicate this is not the case. While some older adults might experience dry mouth, it's usually due to other factors, not just aging itself.
And what are some of those common factors that can lead to this reduced salivary flow?
Medications are a very frequent cause. Many different types of drugs can have this side effect. Antihistamines, antidepressants, antihypertensives, diuretics, muscle relaxants, sedatives. The list goes on. As we've already discussed, xerostomia is also a significant feature of autoimmune diseases like Sjogren's, sarcoidosis, and scleroderma. Other causes include radiation therapy to the head and neck, diabetes, radioactive iodine treatment, HIV/AIDS, and even psychological factors like anxiety and depression. But not just aging. No. That's the key takeaway from the sources on that point.
That's an important clarification. Dry mouth can be so uncomfortable and lead to other oral health problems too. Okay, we've now covered reactive and infectious conditions. Let's move on to growths in the salivary glands, starting with the benign ones. The sources provide a general definition. Non-cancerous, typically slow-growing, no metastasis.
Exactly. And the most common type of benign salivary gland tumor is the pleomorphic adenoma, also frequently called a mixed tumor.
Mixed tumor, why mixed?
The name comes from its appearance under the microscope. It contains a mixture of both epithelial cells, lining the ducts and secretory parts, and mesenchymal components, connective tissue-like cells.
So it's not just one type of cell growing uncontrollably.
Correct. It's a proliferation of both ductal epithelial cells and myoepithelial cells, those cells that help move saliva along, all within a supporting stroma that can vary quite a bit.
Where do these usually show up?
They are most commonly found in the parotid gland. They can also occur in the submandibular gland and in the minor salivary glands, with the palate being the most frequent site in the oral cavity itself.
And who gets them typically?
Pleomorphic adenomas can develop at any age, but are most often diagnosed in adults between 40 and 60, and they affect men and women roughly equally.
What does a pleomorphic adenoma typically feel like? What would someone notice?
They usually present as a painless, slow-growing mass. Often they feel firm and are typically mobile, movable under the skin. However, in the palate, they might feel less mobile, more attached to the underlying bone.
And what's the standard treatment for these benign tumors?
Surgical excision is the primary treatment. If completely removed, the prognosis is generally excellent. However, there's an important detail. They often have a pseudocapsule.
Oh, pseudocapsule.
Yeah, it isn't a true, well-defined capsule, and it can have microscopic extensions of tumor cells beyond it. If the entire tumor, including these extensions, isn't completely removed, there's a risk of recurrence.
Wow. Okay.
Also, although benign, there is a small risk of malignant transformation, especially if it's been there a long time or has recurred before.
Pseudocapsule sounds critical for surgeons to know about. Okay, the sources also briefly mention several other types of benign salivary gland tumors. Let's quickly go through those. First up is canalicular adenoma.
Canalicular adenomas are more often found in the minor salivary glands, particularly in the upper lip of older adults, slightly more in women. They're typically small, freely movable, asymptomatic masses. Microscopically, they have a characteristic look. A double layer of basiloid cells in thin strands or canals in a very vascular stroma. Treatment is straightforward surgical excision.
Next, we have myoepithelioma.
Myoepitheliomas can occur in the parotid or minor glands, also typically painless and well circumscribed. As the name suggests, they're composed entirely or mostly of myoepithelial cells. Treatment is usually conservative surgical excision.
Then there's oncocytoma.
Oncocytomas are relatively rare benign tumors, mostly in the parotid. They're composed of oncocyte cells packed with mitochondria, giving them a granular, pink staining appearance. Treatment is generally conservative surgical excision.
And then we have papillary cystadenoма lymphomatosum, thankfully also known as Warthin's tumor. This one had some interesting associations mentioned.
Yes, Warthin's tumor is the second most common benign tumor of the parotid gland. It has a very strong association with cigarette smoking.
Smoking, really.
Yeah, smokers have a significantly increased risk. It typically affects older adults, 50s to 80s, with a notable male predilection. Clinically, it's often a painless, slow-growing mass in the parotid, but unlike the firm pleomorphic adenoma, Warthin's can feel doughy or even cystic.
Doughy or cystic. Interesting texture.
Microscopically, it's unique with both epithelial and lymphoid components. The epithelial part forms papillary projections in cystic spaces lined by a double layer of oncocytic cells. The lymphoid part has a dense stroma with numerous germinal centers. The cystic spaces often contain a pink staining fluid.
How's it treated?
Diagnosis might be suggested by imaging, but biopsy confirms. Treatment is surgical removal, typically a superficial parotidectomy preserving the facial nerve. Prognosis is excellent, very low risk of recurrence or malignant transformation.
That link with smoking is definitely a key point about Warthin's tumor. Finally, in our benign category, we have basal cell adenoma.
Basal cell adenomas are also more common in the parotid, older adults, slight male predilection, typically slow-growing, painless, firm masses. Microscopically, they're composed of basaloid cells, small, dark staining cells in various patterns. Treatment is conservative surgical excision. The sources note some subtypes might have a slightly higher recurrence rate.
All right, we've now navigated the landscape of benign salivary gland tumors. Let's move on to the discussion of malignant ones. Our sources define these as cancerous growths, varying aggressiveness, potential for metastasis. First up, mucoepidermoid carcinoma.
Mucoepidermoid carcinoma is actually the most common type of malignant salivary gland tumor overall.
Most common malignant one. Okay.
Yeah, most frequent in the parotid, but can occur in any gland, any age, though peak is third to fifth decades. Typically presents as a swelling, often painless initially, but higher grade, more aggressive tumors may cause pain and ulceration.
What does it look like microscopically?
Microscopically, these tumors have a mixture of three main cell types: mucus cells, epidermoid cells, like skin cells, and intermediate cells. They are graded low, intermediate, or high based on cellular features and growth patterns.
And the grade matters a lot.
Hugely! Grading is significant for treatment and prognosis. Treatment is typically surgical excision, and radiation might be added, especially for higher grade or high-risk lesions. Prognosis varies considerably with grade. Low grade is much better than high grade.
So the grade of the tumor is a really crucial factor. The sources then briefly describe several other types of malignant salivary gland tumors. Let's touch on those. First, polymorphous low-grade adenocarcinoma.
Polymorphous low-grade adenocarcinoma almost exclusively occurs in the minor salivary glands, palate most common. Affects older adults, typically slow-growing, firm, non-ulcerated mass. Microscopically, they show various growth patterns but have uniform-looking cells with minimal atypia. Treatment is wide surgical excision, prognosis generally very good, low recurrence.
Next, we have adenoid cystic carcinoma.
Adenoid cystic carcinoma is considered high grade, can arise in major or minor glands. Often slow-growing mass, but notable for frequently causing pain, sometimes severe, and can involve the facial nerve.
Facial nerve involvement.
Uh,
Sounds serious.
It is. Microscopically, it has distinctive cribriform, Swiss cheese-like, tubular and solid patterns. A hallmark is perineural invasion. It tends to spread along nerves. Treatment is typically wide surgical excision, often followed by radiation. Unfortunately, despite initial control, the long-term prognosis tends to be less favorable. High rate of local recurrence and distant metastases, often years later.
Clear cell carcinoma.
Clear cell carcinoma is relatively rare, typically low-grade, primarily affects minor glands, often palate, presents as a submucosal mass, microscopically characterized by tumor cells with clear cytoplasm due to glycogen. Primary treatment is surgical excision, generally uncommon recurrence, and good prognosis.
Actinic cell carcinoma.
Actinic cell carcinoma predominantly arises in the parotid, can affect any age, but most often 5th and 6th decades. Typically slow-growing mass, sometimes painful. Microscopically, tumor cells resemble normal acinar cells, the serous saliva producers. Various growth patterns. Primary treatment is surgical excision. Prognosis generally considered good compared to some others, but still potential risk of recurrence and metastasis, sometimes years later.
And our sources also briefly mentioned a few other even rarer malignant salivary gland tumors, including carcinoma X mixed tumor. That sounds like a malignancy arising from a benign tumor we discussed earlier.
Exactly. Carcinoma X-mixed tumor is when a previously benign pleomorphic adenoma transforms into cancer. It's more aggressive, requires aggressive surgery. The sources also list epimyoepithelial carcinoma, salivary duct carcinoma, and basal cell adenocarcinoma as other less common types. Some might be malignant counterparts of benign ones or arise newly.
Finally, to summarize the key distinguishing features between benign and malignant salivary gland tumors, what are the main things to consider?
Malignant tumors tend to grow more rapidly. They might ulcerate, feel fixed or attached, and sometimes involve the facial nerve, causing weakness or paralysis. Pain is also more common with malignant tumors.
And metastasis.
Crucially, yes, malignant tumors can metastasize, spread distantly. Benign tumors do not. Benign tumors are typically well encapsulated, easier to remove completely. Treatment approach and prognosis differ significantly. Malignant often needs more aggressive treatment like radiation and has a more guarded prognosis.
So as we've explored in this deep dives, there is a really wide spectrum of conditions that can affect these seemingly simple but absolutely vital salivary glands. From those common reactive lesions to infectious and systemic diseases, and then a diverse range of both benign and malignant growths.
That's absolutely right. And the most important takeaway for you, our listener, is that if you experience any persistent or concerning symptoms related to your salivary glands, unexplained pain, swelling, persistent dryness, or finding an unusual lump seeking professional medical evaluation is absolutely crucial. Accurate diagnosis is the first and most important step towards appropriate management and ensuring the best possible outcome.
Indeed. So, the next time you experience a seemingly minor mouth annoyance, remember the intricate world of your salivary glands and the incredible complexity of our bodies constantly working to maintain balance. What other hidden systems within us are operating tirelessly, often without our conscious awareness? And what might we learn by paying just a little more attention to the subtle signals our bodies send? It's definitely something to think about. Thanks for joining us for this deep dive.